Diphenhydramine. Introduction and history. Diphenhydramine is basically antihistaminic drug which blocks the action of histamine by binding to the histaminic H1 receptors in our body. History. In 1943, George Reeves School and Miles S. Reed at University of Cincinnati synthesized diphenhydramine as a part of their investigation on compounds related to acetylcholine. Their initial objective was to make alternative of scopolamine, which is anticholinergic, an anti-motion sickness drug, which was widely used in Second World War to avoid seasickness among naval personnel, and as a truth serum for prisoners. By experimenting this drug on guinea pig ileum, it was found that this drug also has antihistaminic properties in addition to potent muscle relaxant. In 1946, it was approved by FDA as OTC drug. Class of drug. Diphenhydramine belongs to H1 receptor blockers. This subtype of antihistamines is used to treat allergy symptoms. First-generation antihistamine. First-generation antihistamines work on histamine receptor in the brain and spinal cord. It is an ethanolamine derivative containing amine and OH group. Chemistry. Benzhydrylbromide 2-dimethylaminoethanol. Diphenhydramine. Mechanism of action. Release of histamine. H1 receptor and histamine. Diphenhydramine action. Diphenhydramine acts as an inverse agonist at the H1 receptor, thereby reversing the effects of histamine on capillaries, reducing allergic reaction symptoms. It readily crosses the blood-brain barrier and inversely agonizes the H1 CNS receptors, resulting in drowsiness and suppressing the medullary cough center. It is a competitive antagonist of muscarinic acetylcholine receptor. Pharmacokinetics. Absorption. Well absorbed in the gastrointestinal tract after oral administration. The onset of action occurs within 30 minutes. Distribution. Readily distributed throughout the body. It crosses placental barrier and blood-brain barrier. Metabolism. Metabolized by the cytochrome P450 enzyme system in the liver. Minor metabolic pathways are hydroxylation and glucuronidation. Excretion. Elimination half-life is 2 to 9 hours in adults. Majority of the drug and metabolites are excreted in the urine, with less than 1% excreted unchanged. Oral bioavailability of this drug is 40% to 60%. Therapeutic uses. Insomnia, because diphenhydramine has strong sedative properties as it crosses blood-brain barrier. Motion sickness and nausea. The antiemetic action of this drug is due to the blockade of M1 muscarinic receptors. Parkinson's disease. Diphenhydramine is known to be at least partially effective in Parkinson's disease, perhaps because of its anticholinergic properties. Allergic and inflammatory conditions. It is useful in the treatment of allergic symptoms such as rash, sneezing, itching, hives, runny nose, watery eyes, cough and sneezing. Diphenhydramine. Adverse effects and contraindications. Adverse effects. Anticholinergic effects. Constipation, blurred vision, urinary retention, dry mouth, confusion. Antiadrenergic effects. Hypotension, serotonin blockade, increased appetite. Contraindications. Diphenhydramine hypersensitivity. Premature infants and neonates. Breastfeeding mothers. Toxicity and dose. Recommendation. Toxicity. Overdose of diphenhydramine causes hallucinations, delirium, seizures, coma, death. Antidote. Physostigmine. Dose recommendation. For adults 12 years or older, 25 to 50 milligrams every 4 to 6 hours. Insomniac patients, 25 to 50 milligrams 30 minutes before bedtime. For children 6 to 11 years, 12.5 to 25 milligrams every 4 to 6 hours. For children under 6 years, the medicine should be taken under the guidance of healthcare professional as dosing is based on child's weight and other circumstances. It can interact with medications like antidepressants, antihypertensives and anticonvulsants, and disturb heart rhythms or increase risk of side effects. Brands and dosage forms. Brands. Dosage forms: Benadryl, Alearmax, Sominex, Benufen, tablets and capsules, syrups, injections, topical creams and gels, chewable tablets. Acefil. Comparison with other antihistamines. Sleep aid, availability, rapid onset of action, cost, antiemetic. Case study. Patient, Sarah, age 52, medical history, Sarah had a history of chronic obstructive pulmonary disease, COPD. She was on multiple medications for these conditions. Presenting symptoms, Sarah developed a severe allergic reaction after consuming a new food item, which led to symptoms such as itching, hives, difficulty breathing. Treatment. She was taken to the emergency department, where she was diagnosed with the anaphylactic reaction. In addition to receiving epinephrine and other appropriate emergency treatment, she was given intravenous diphenhydramine to help alleviate her allergy symptoms.